السلام عليكم. صباح الخير جميعاً. Welcome back everybody. We will start now inshallah session 3. This is Ashwaq, the Vice Dean of College of Medicine. And we will start session 3. We will have inshallah 5 of our researcher students. They will present over 10 minutes. Then after each we will have 5 minutes for discussion and comments and questions. We will start inshallah with Dr. Rima Farhan Al-Gahtani. She's last year medical student, and she will present the association between physical activity level and severity of knee osteoarthritis. Best of luck, Dr. Rima.
Assalamu alaikum, good morning. I am Rima Farhan Al-Gahtani, medical student at King Khalid University. On behalf of my team, I will present our research site entitled The Association Between Physical Activity Level and Severity of Knee Osteoarthritis, a single-center study in Saudi Arabia. Before I start, I will point some facts about osteoarthritis. First, knee osteoarthritis is a disabling joint disease that results in degeneration of the joint cartilage. Osteoarthritis is a frequent progressive disorder that's featured by chronic pain with functional disability. Globally, knee osteoarthritis is representing for nearly 80% of the burden of osteoarthritis, which is mainly associated with obesity and age. Until now, there is no effective treatment for knee osteoarthritis except of knee arthroplasty, which is considered the main treatment at progressive stage of the disease. The main of our study is to assess the impact and the association of physical activity level with the severity of knee osteoarthritis among patients attending a single center in Asir region, Saudi Arabia. The method and the material that we used, analytical cross-sectional study, started at June 2021. We targeted all patients clinically diagnosed with knee osteoarthritis attending the orthopedic and rheumatology clinic at Khamis Mshaid General Hospital. Data extraction, it was revised and coded and fit to statistical CBSS software. Analytical cross-sectional study was conducted using pre-structured questionnaire. We targeted all patients diagnosed with knee osteoarthritis in Asir region from June to September 2021. The questionnaire included participant socio-demographic data, including gender, job, and comorbidities. Also clinical data regarding knee osteoarthritis, such as duration, medication beside knee surgery, and trauma. The level of physical activity was assessed using the International Physical Activity Questionnaire, and the severity of knee osteoarthritis was assessed using the Index of Severity for Osteoarthritis of the Knee. Our inclusion and exclusion criteria: patient aged less than 35 years old, patient who diagnosed with osteoarthritis other than knee osteoarthritis, such as hip osteoarthritis and ankle osteoarthritis, patient with medical condition that might affect the physical activity level, such other than osteoarthritis or rheumatoid arthritis, like osteoporosis or fracture, were excluded. I'm going now to explore our results. Out of 473 patients clinically diagnosed with knee osteoarthritis, only 145 patients met our inclusion criteria. Patient ages range from 35 years to 71 years, with mean age of 44 years old. A total of 84% of our patients were females. and 44% of patients complained of knee osteoarthritis for less than 2 years. Rheumatoid arthritis was the most frequent reported comorbidities. This table, it will represent the distribution of the knee osteoarthritis severity by patient biodemographic data. First, the age. Our study report, that 90% of our patients have very to extremely severe knee osteoarthritis of patients who had more than 65 years old, and compared to 38% who age less than 40. About the gender, we can see in this table that 55% of female patients had very to extremely severe knee osteoarthritis, compared to 30% of males. Regarding to the duration of diagnosis, we can say the extremely severe knee osteoarthritis detected among 49% of patients diagnosed with knee osteoarthritis in less than 2 years. Out of patients who had knee osteoarthritis, who had knee joint trauma, 65% of our patients having knee trauma compared to 41% who had no trauma. In this table, I would like to explore and focus on the association between physical activity level and severity of knee osteoarthritis. Among males, there is 53% with a low physical activity level had very to extremely severe knee osteoarthritis, compared to none of those with moderate to high physical activity level. Among females, there is 69% had very extremely severe knee osteoarthritis with low physical activity level, compared to 26% had very extremely severe knee osteoarthritis with high physical activity level. In total, 67% of our patients have, with low physical activity level, had very extreme severely knee osteoarthritis, compared to 23% have a high physical activity level. And the first figure here, it is represent the severity of knee osteoarthritis among the study patients. We can see here a total of 26% had extremely severe knee osteoarthritis, 25% have very severe knee osteoarthritis, 90% have severe knee osteoarthritis, 50% have moderate knee osteoarthritis, and 9% had mild knee osteoarthritis, and only 4% have minimal knee osteoarthritis. In the second figure here, it represents the level of physical activity among patients with knee osteoarthritis in our study. We can see here that most of our patients, 66% of our patients, have low physical activity level. 22% have moderate physical activity level, and only 11% have high physical activity level. I would like to discuss some points here. First, knee osteoarthritis is one of the highest 5 reasons of disability among adults in the United States, and it is commonly reported in the clinical setting, so physicians should be address patient worry about pharmacological and non-pharmacological management to the knee osteoarthritis. Second, exercise is one of the most announced and controversial non-pharmacological management approach for knee osteoarthritis. Third, knee osteoarthritis is a disabling joint disease that results in degeneration of the joint cartilage. There is many studies that demonstrate the risk factor and the complication of knee osteoarthritis, but how the physical activity impact the osteoarthritis severity need to be studied. So the aim of our study is to assess the level of physical activity in patients with knee osteoarthritis. Also, it's limited to assess the impact of physical activity level on the severity of knee osteoarthritis. Lastly, exercise therapy for osteoarthritis benefit is still doubtful, which is designed and prescribed for specific therapeutic goals. And in some studies, exercise show effectiveness in minimizing symptoms and disability. And on the other hand, there is some study showing that the intensity of knee in osteoarthritis patient linked to increased physical activity. Our limitation in this study is included knee osteoarthritis patient a rheumatology clinic beside orthopedic clinic, which might affect the significance of the association address. Some patients were included who diagnosed with rheumatoid arthritis, We conducted analytical cross-sectional study, hence we couldn't assess the temporal link between variables due to the strangest inclusion criteria we chosen. We exclude many patients, which might affect the quantities correlation. In conclusion, the study revealed that the physical activity, especially high levels, was associated with lower knee osteoarthritis. Most of the study patients had severe to extremely severe knee osteoarthritis with low physical activity level. It's obvious that light to moderate intensity physical activity had beneficial impact on knee osteoarthritis severity. There is a significant evidence in the literature that many forms of exercise, as well as less conservative approach, showed a positive influence in osteoarthritis severity and associated impairments. Here is our references. And at the end, thank you for listening. I hope you enjoyed it, and I would be happy to answer your question.
Thank you, Dr. Rima, for your presentation. Anybody is having any questions for Dr. Rima? Yes, تفضل Dr. Khaldi.
Thank you, Rima, for your presentation. It's a very good presentation, very well projected, and you're well spoken, clear. So there's always a problem with study of association, that how can you control for confounding factors? And I'm a bit confused. So is low physical activity is associated with severe osteoarthritis, or is it the other way around? Patient who has severe osteoarthritis, they're not able to exercise, and that is the reason why they have low physical activity. So how can we answer this? The second thing, did you adjust or did you analyze the cause of the osteoarthritis? So for example, patient who is obese, he might not exercise because of obesity, and that will affect his osteoarthritis. So again, I'm not clear if the low physical activity is a result here or is the cause of aggravating the osteoarthritis. Thank you.
Okay. Many of patients of knee osteoarthritis always ask if the exercises will affect my osteoarthritis, it will make it worse, because they have this assumption that wear and tear phenomena, that the physical activity will accelerate the degeneration process in the cartilage. But according to our study, many of patients have severe to extremely severe knee osteoarthritis due to low physical activity. A patient also, there is an other study showed that patients who reduce their weight and do exercise, they have improved and minimized in their symptoms and decrease in the pain.
Thank you.
Thank you.
Other questions? Comments for Dr. Rima? No.
Thank you, Dr. Rima, for this excellent presentation. Just I'm wondering now, what is the next step based on your findings now and your conclusions?
Sorry, doctor, can you repeat it?
What is the next step? If you would like to confirm your conclusion, as Dr. Hussein said that we don't know actually in cross-sectional studies which one come first, or they might not exercise because they have already have a severe osteoarthritis. So to confirm this association, what you will do next in terms of another research?
I think our research should be a multicentric study around Saudi Arabia to know the variation.
Are you going to change the design of your study?
Yeah, maybe meta-analysis or systemic review.
Okay, maybe. Okay.
Thank you, Dr. Arima, for your great effort. Best of luck.
Thank you.
Okay. Our second presenter is Dr. Abdullah Alimshari. He is last year's medical student at King Khalid University. He will present research titles Common Morbidities Associated with Rheumatoid Arthritis Patients. Dr. Abdullah, mic is yours.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. We appreciate this opportunity and we hope to give you a good impression for our research, which is talking about the common morbidities associated with the rheumatoid patients. It was an honor and pleasure to work with Dr. Mansour Smaili, Dr. Shahinda Yusuf, also with my colleagues Munif Al-Qahtani, Saad Al-Asmari, Abdullah Sbai'i, Abdullah Hassan, and Abdullah Alimshari spoke to you. The rheumatoid arthritis is chronic multisystemic inflammatory disease which is affecting the synovial part of the body, and also it is affecting 1% of the whole population of the world. Also, the rheumatoid arthritis is a known etiology, and there is many susceptibles of this disease, such as a female patient, older ages, and who had cigarette smokings. The rheumatoid arthritis signs and symptoms are demonstrated as synovitis, morning stiffness, and arthralgia in hands and feet. The common morbidities that associated with the rheumatoid arthritis are recognizably increased through the population and leading to increased mortality, such as the cardiovascular disease and osteoporosis. There is many research that are reported this relationship between the rheumatoid arthritis and these common morbid conditions, such as the Linda et al. Reported there is 73% of the rheumatoid arthritis patients have a common morbid conditions. From that, our research are assumed to determine this relationship and demonstrate it to the population. The objectives of our research to determine this relationship and introduce the data to the population and help to prevention and early diagnosis of these common morbidities. We are done our research in retrospective cohort study, and we are do it in Khamis Mshaid General Hospitals. We are retrospectively reviewed 150 patients of the rheumatoid arthritis in Khamis Mshaid General Hospitals. 128 from these patients were female patients, by 85% from these patients, and 22 male patients. That which is prescribed the increase of the female patients in rheumatoid arthritis. The age range of our study is determined by between 18 and 75 years old, and also the timeline or the main disease duration of since the diagnosis of the disease, and our study it is between 8 years. Here in this figure, we see the percentage of the common morbidities associated with the rheumatoid arthritis. We can see firstly the anemia, which is participated by 48.7%, and comes secondly hypertension by 32.7%, and thirdly the hyperlipidemia and diabetes mellitus by 27.3%. The methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine, these agents are known as DMARDs, which is anti-rheumatic agents that a lot of rheumatoid arthritis patients are using. And when we see here the 24.7 of our patients are using 2 or more of these demands. The biologic therapy was prescribed for our patients, and a lot of them are used. In the firstly, there is adalimumab. It was the most prescribed first-line biologic by the 27%, and secondary come to it tocilizumab and other agents. Also, our patients, none of them had abnormal chest X-ray or abnormal PPD test for the skin, and abnormal infection or cancer during the duration of disease. For our study, here we know the relationship between the rheumatoid arthritis and the most common morbidities, such as the anemia, hyperlipidemia, hypertension, and diabetes mellitus. From that, we know the importance of prevention and early diagnosis for these common morbidities and determine it. These are our reference for our research, and also here. Thank you so much for listening, and we are open-handed for any question.
Thank you, Dr. Abdullah. The floor is open for any questions. Any question? المايك.
Thank you so much. Actually, I have a question regarding comorbidities of females. You said we have a strong association between the female and rheumatoid arthritis as the comorbidities. You mean female in general or certain age of the females?
Can you repeat the question, please? I can't hear it.
I mean, you said we have a strong association between female gender and rheumatoid arthritis as a comorbidities. It depends on the age of the female itself, or not necessary?
Not necessary to depend on the age. There's a lot of rheumatoid arthritis patients as female patients.
I see.
Any question?
Thank you, Abdullah, for this nice presentation, nice study. So again, comment about the slides style. PowerPoint presentation is not like writing manuscript. You do not need in-text citations. 1, 2, 3, 4. You don't need them. Either you add the author's name or just a brief citation at the end of the sentence. And again, they are not sentences, they are phrases only. So you don't need a paragraph in PowerPoint presentation. Just a bullet points that are summarizing the main message of the slide. So this is a comment. The question is, what is the main conclusion of the study? Can you phrase it in 1 or 2 sentences?
Can you repeat it, please? I'm sorry, I can't hear.
Sorry, because of the echoes. What is the main conclusion of your study?
The main what?
Conclusion.
The main conclusion. Here we can describe the results of the rheumatoid arthritis on the patients, which is affecting the lifestyle of the patients. He can't walk or can't do his workout, which leading to many diseases such as obesity, diabetes mellitus, hyperlipidemia, like that.
Thank you. I think the message is rheumatoid arthritis patients have a lot of comorbidities.
Yes.
And if you count how many times does the patient, a single patient, come to the hospital in a month or 2 is a very unbelievable number.
Yes.
So the main message is to create a multidisciplinary team that could help those patients stay out of the hospital, get the maximum benefit, combining people, rheumatoid arthritis specialists, cardiology, primary care physicians at one clinic. So this is a model that has been started in developed countries, is to make the patients, comorbid patients' lives easy. So he will come to the internal medicine consultant today, and rheumatology specialist tomorrow, and the hematologist after that, and he will refill medications after that. So I think this is the main message from the paper. Thank you very much for the great
You're
work.
welcome. I appreciate, Dr. Ali.
Okay, just one comment. Again, our objective is to enhance your research. Usually, conclusion is based on your results. Your last statement in the conclusion is not related to your work. You mentioned that rheumatoid arthritis patients will affect their mortality and morbidity. You, in your study, you have not touched mortality at all. So please remove this word from your conclusion. You are not measuring mortality at all. You measure comorbidities, not mortality. Okay, thank you.
Thank you so much, Dr. Ahmed.
Okay, best of luck, Dr. Abdullah. Let's welcome next presenter, Dr. Al-Walid Al-Shahri. He is last year medical student at King Khalid University, and he will present his research, which is about kidney-related quality of life in peritoneal dialysis compared to hemodialysis, which is, I think, really important. Dr. Walid, the floor is yours.
السلام عليكم ورحمة الله. Hello everyone, good morning. My name is Al-Walid Al-Shahri. I'm a final year medical student in King Khalid University. According to a 2019 report by the Saudi Center for Organ Transplantation, we have more than 28,000 patients suffering from end-stage kidney disease, of which 69% are undergoing hemodialysis, followed by 25% who are undergoing, who are post-renal transplantation, and then 6% who are undergoing PD. In the southern region, we have a total number of 3,000 patients who have end-stage kidney disease, of which only 4% are undergoing PD, which is the lowest percentage in Saudi Arabia. So, we have three main treatment modalities for end-stage kidney disease. It's either by hemodialysis, or by peritoneal dialysis, or by renal transplantation. But the main difference between PD and HD is that in PD, it's usually delivered at home, which provides the patient with greater independence and self-control over the time and place of treatment. Whereas in HD usually needs the patient to commute frequent times to dialysis centers with a tight schedule and timing. So, our main objective of the study was to compare between the quality of life of patients undergoing HD and PD, and that would help us and help the patients and the healthcare providers to determine which kind of modality suits the patients better and their families. So, we decided to conduct a study. After reviewing all the relevant literature, we conducted a cross-sectional study that we used as a questionnaire. Sorry, we conducted a cross-sectional study that meets the objectives of the research by using a validated and translated version of the kidney disease quality of life short form, and that will help us to assess the quality of life differences between patients undergoing peritoneal dialysis and hemodialysis. And we also encourage the patients to fill the forms by making it as easy as possible. We handed out tablets to nurses in dialysis centers who are very cooperative with us. And after that, the nurses hand out the tablets to the patients to be self-filled by the patients themselves. And that also helped us to avoid any interviewer bias. So, our study population were all the patients, either males or females, with end-stage kidney disease who are over 18 years of age and are on dialysis for more than 3 months, and also using peritoneal dialysis or hemodialysis in ICR region only. And we excluded any patients who had any mental or physical inabilities that made them unable to fill out the forms themselves. And our data entry and analysis was done by the SPSS version 22.0. So the results showed remarkable differences between the quality of life in patients who are on HD and patients who are on PD, especially regarding 5 areas. The first area was restrictions on the nature of work that they could do and their daily activities, and also on pain, if it causes any difficulties on their daily tasks, and if the patients were experiencing any frustration as a result of their kidney dysfunction, and also in terms of numbness in hands and feet, and having any frustration or difficulties with the catheter site. So to make it clear, we prepared these 2 diagrams. When we asked the patient, how much would you rate the pain and its interference on your daily activities, the results were completely different and significant. So as you can see on the diagram on the left, which represents patients undergoing hemodialysis, the majority of the patients did report that hemodialysis greatly affected their lives and daily activities. But on the other hand, it was very contrary. PD patients didn't actually report any serious complications or any serious difficulties in performing their daily activities. And when we compared the 2 groups statistically, we found a significant difference and a p-value of 0.007. So as a conclusion, in terms of pain and daily activities, patients undergoing PD were linked to have a greater quality of life in end-stage renal disease. And we found out that in order to enhance the quality of life in patients undergoing PD or undergoing HD, specific treatments should be targeted to be focused also on the areas of discontent. And PD, we found out that PD might be associated with greater quality of life and is more preferred over HD unless there is a greater indication to perform hemodialysis. Before I conclude my presentation, I'd like to acknowledge all the efforts of all the doctors, physicians, and nurses in the Armed Forces hospitals of the southern region, also in ICR Central Hospital for helping us to collect all this data, also in Davita, Saudi Arabia. At the end, I'd like to thank all the organizers for their hard work and dedication. I'd like to thank you all for listening and attending, and I hope you have a great day. If anyone has any questions, now is the time.
Thank you, Dr. Walid. You really have a magnificent presentation skills. You owned the stage, mashallah, and you presented your points very clearly, and you didn't forget your team, definitely. So, anybody has any question for Dr. Al-Walid? Yes, there is one.
Thank you, Dr. Walid, for this great presentation. May I ask you, what statistical test was used to obtain these results?
We used the Mann-Whitney test because we are comparing between two ranks of independent groups.
Thank you.
Thank you. Any more questions?
Questions, comments? Dr. Walid, what makes your research unique? Why would I cite your paper?
I'm sorry, but I can't hear you very well.
Yes. Now is it clear?
Yeah.
What makes your paper unique? Why would I cite your paper while already I know, and I have a lot of papers, other papers, that tells me that the quality of life of PD patients better than HD patients?
Actually, after reviewing the literature in Saudi Arabia, we didn't find anything that is related to this topic right here in Asir region. We found a previous research, but it was made in the western region, in Jeddah, Mecca, and the regions close to it, but nothing in Asir region.
Thank you very much. So definitely we
You're most
always
welcome.
need local numbers and papers about our patients. Any more questions or comments? We have Dr. Ali.
Thank you very much. Very interesting, Walid. I have a question about, I know it's not the scope of your paper, but when you revise the literature about the PD and HD, are there any data about the long-term morbidity and mortalities comparing the two? Because quality of life is something short outcome. Are there any data about the long-term quality of morbidity, mortality, and?
Maybe after collecting all the data and trying to exclude something else, maybe we can figure that out in the future. But the main objective of our study was to compare the quality of life between PD and HD patients, not the mortality and morbidity rates.
I know, but I meant in the literature. Did you find anything?
There was some literature that mentioned that hemodialysis had better effect than PD, but nothing right here in the southern region, nothing local, maybe abroad.
Thank you very much, Dr. Al-Walid. Best of luck.
Thank you. I hope you all have a good day.
Our next presenter, Yazid Mohammed Abed. He is 5th year medical student at King Khalid University. He will present a research titled Association between Initiation of Cigarette Smoking and Generalized Anxiety Disorders among Medical Students in Saudi Arabia 2021. Dr. Yazid, mic is yours.
شغلته؟ بسم الله. السلام عليكم ورحمة الله وبركاته. I am Yazid Mohammed bin Abed, 5th year medical student, and today, on behalf of my author, Dr. Abdulaziz Abu Dasser, and my co-authors, I will be representing our research association between initiation of cigarette smoking and general anxiety disorder among medical students in Saudi Arabia. First, what's general anxiety disorder, or GAD? It's characterized by excessive and exaggerated anxiety and worry over daily life events for no pattern reason. So it could affect your daily activities, it could limit you, and of course it requires a long process of treatment, including cognitive therapy and pharmacological. And smoking, considered, as we all know, a physical a habit of both, a damaging habit for both physical and psychological. The physical is known for everyone, but how could the smoking cause a psychological impact or damage? An example, in GAD or anxiety, general anxiety disorder, it can actually exacerbate symptoms of anxiety, especially in case with withdrawal symptoms. Regarding the general anxiety disorders, we use the DSM-5 to diagnose it. There is 5 or 6 symptoms. The patient needs to have 3 for at least 6 months. Cigarette smoking is one of the most common risk factors of general anxiety disorders based on a research conducted at United States. Roughly 15% of ever smokers have had at least one episode of anxiety, compared to about only 3% of non-smoker population. Self-administration of nicotine through smoking might cause anxiety, as dysphoria is one of the observed pharmacological effects of nicotine. A research by the National Comorbidity Survey replication confirmed a close association between general anxiety disorder and smoking. So we talked about smoking, we defined general anxiety disorder, but how huge the problem is. In Saudi Arabia, there was a first study conducted at King Saud University to see the prevalence of smokers. It was conducted on students in College of Applied Medicine Science. Out of 647 response, the percentage was 29. Another study, which was conducted on our target population, medical students, attempted to estimate the prevalence of smoking and understand the attitude, practice, and knowledge among medical students in Medical College of King Abdulaziz University in Jeddah. Out of 643 participants in the study, 90% of 90 students, 14% of these medical students, they were smokers. And the last study was cross-sectional, which gave us a hint about the relation between general anxiety disorder and the smoking. So I talked a lot in the introduction, but our aim in our research is the present study aims to determine the association between initiation of cigarette smoking and GAD among medical students in Kingdom of Saudi Arabia. Our study was a cross-sectional study, a questionnaire, multiple choice answers. Regarding the anxiety or general anxiety disorders, we used or depend on the GAD-7 and not patient, the participant choose whether he's suffering from these symptoms always or never. And regarding the smoking, we added some questions related to smoking cigarettes, such as a frequency of smoking, age when he starts smoking, and when he feels stressed, whether smoking helps reduce the stress or not. The survey was conducted on 307 medical students from 18 universities across 11 regions from Kingdom of Saudi Arabia. The study was conducted during the period of July 21 to December 21. First, we were shocked about the percentage of medical students who were diagnosed with mental or confirmedly diagnosed with mental disorder. Nearly 20% of the participants had mental disorders. GAD being the most of them, like 80%, depression, panic attacks, OCD or obsessive compulsive, and others. And regarding the anxiety part, first question was, do you feel nervous, anxious, or on the edge? And nearly half or more than half had it for several days. And do you easily become annoyed or irritated? Also, more than half of the students said yes for several days. The third question, do you worry too much about different things? There were a good percentage that they say several days. Do you face trouble when relaxing? Also, the same thing, high frequency. And the last question was, do you feel so restless that it's hard you to sit still? And the percentage as shown in the chart. So regarding the smoking, the present study was shown a grimmer picture in terms of percentage of medical students who smoke, 24.75% compared to the last study was conducted, it shown 14% only. So it was conducted in 2011, 10 years, and the percentage increased 10%.
3 minutes left.
All right. If you smoke, how long have you been smoking? These two questions, and when did you start smoking, represent the correlation between the medical student, the start of the journey, and when did they smoke. Like most of the students start smoking while they're in the college. Have you tried or thought of smoking when you feel stressed? Out of 307, 120 participants said they have thought or tried smoking to to calm or relax. And half of them nearly said it helped them reduce, and the other half said no, it didn't. Conclusion, the present study demonstrates that smoking is unfortunately quite widespread among Saudi Arabian medical students who will shortly be leaders and role models in the healthcare. Hence, more effective way to reduce this bad habit are required. More comprehensive study is needed to be conducted to get more reliable and representing picture of the phenomena. The study also recommends further research on the medical students' perception on the association between smoking and mental disorder, and this will help policymakers to have better understand and address the prevalence of smoking, especially in the medical students who are supposed to be in the top of the health in the health facility and help people to quit. While we are studying, we focused only on regular tobacco smoking, and in the meanwhile, at the same times, the habit of electronic cigarette smoking is becoming more and more prevalent among the whole population and the medical students in this group, the participant age group specifically. So we recommend further contributing research regarding starting this bad habit. These are our references. And thank you.
Thank you, Dr. Yazid. Any questions? Can you give the mic to Dr. Muhammad, please?
Thank you, Dr. Yazid, for your interesting talk and seminar. I have two questions. The first one, why did you specify medical student for your study? First. The second one, do you have the intention to do and run the same experiment and study to other students?
Again, the second question, again?
Do you have an intention to run the same study on the other students for other colleges?
All right. First, why medical students? I'm a medical student. I've had a lot of psychological and involved in problems while studying. I had anxiety a lot of times. It's limited me a lot, and I had the idea of starting smoking. And at the same time, I saw a lot of students who are smoking and have the same thing. And a lot of the research are not focused on the health and the people who work for health, doctors or whatever. It's focused on the population. So I decided to focus my research on the medical students. This is the first question. The second, yeah, I'm really, especially the prevalence of smoking generally, because I think with the new electronic smoking, the prevalence is hugely increasing. So yeah.
Thank you. Any other questions?
السلام عليكم.
عليكم السلام.
هنا لجنة التحكيم هنا يا شيخ.
معلش.
Can you just يعني explain more how did you select your participants among medical students?
All right. Firstly, it's cross-sectional study. The participants have agreed on participating, and the second thing is, are you medical students or not? There is the participants were 410, and out of them there were 307 medical students. So there is more participants, but we didn't conclude them in the analysis.
For medical student, how did you select them in your
can't
study?
hear you, I'm sorry.
How did you select them? كيف اخترتهم في الدراسة? How did you select your sample?
أنا جايك عشان أسمع بدون مايك معلش. طيب, questionnaire regarding most of the participants were from King Khalid University. For me, I personally يعني entered into each group. كل دفعة كنت أدخل عندهم and ask them to participate, and they were really helpful. And my co-authors also participate in helping spreading it. Regarding the other regions, we didn't have data collectors, but we tried our best to communicate with other medical students from other colleges, and we were able to maintain data from 18 colleges, 11 different regions. So alhamdulillah.
طيب, with this approach, خلاص, with this approach of sampling, do you think you have some limitations or selection bias?
In what?
يعني هل عندك limitations أو مشاكل في السامبلينج تكنيك تتوقع؟
Yes, I'm limiting everyone who's not a medical student. I couldn't understand the question. Sorry.
Those who are going to respond and agree to participate in your research, I think they are those with the general anxiety disorder.
Only?
How do you comment?
Well,
يعني ما استجاب لك ولا دخل معك في الدراسة.
I get it. Yeah, I get it. Well, in the introduction, I present a lot of study that show representative numbers like our results. So if our sample was only generalized, how come it's general anxiety disorder patients or participants? How come the other peer researchers have similar results? This is the first thing. Second thing, I think I answered the question conformally, but we tried to take it from all the medical students, and most of us are required to have or do at least one research before graduating. So the community of the medical students is really helpful. All of them participate and hope to help each other. يعني متحدين نقف متفرقين نسقط.
Thank you, Dr. Yazid.
شكرا.
Let's welcome Dr. Jawahir al-Sharif, our fifth presenter today. She is senior medical student, King Saud bin Abdulaziz University for Health Sciences, Jeddah. And she will present her paper of botulinum toxin type A for lower limb lengthening and deformity correction, which is a systematic review and meta-analysis. Dr. Jawahar, the floor is yours.
Okay, this is the pointer. Okay, so is my voice clear? Can you hear me? Okay, I can use the other one. Okay, let's start. So, greetings, this is Jawahar Sharif, a senior medical student at King Saud bin Abdulaziz University for Health Science. In the next few minutes, I'm going to talk about our first level of evidence systematic review and meta-analysis, in which we aim to compare the effect of botulinum toxin type A to placebo during lower limb lengthening and deformity correction. To further introduce the topic, the botulinum toxin type A is the most popular therapeutic agent for muscle relaxation as well as pain control. Lately, botulinum toxin type A received a great interest as a part of multimodal pain management for lower limb lengthening and deformity correction. So question, what is the significance of our study? Recently, there is a number of randomized control trials, i.e. RCTs, has been introduced to the literature comparing the desired arms. And a debate was raised about the routine use of the botulinum toxin type A injection during such operations. And up to our knowledge, there was no systematic review and meta-analysis was done before about this condition. So we raised the question and aimed to answer this question. In individuals who are undergoing surgical lower limb lengthening as well as deformity correction, is intraoperative botulinum toxin type A injection safer and more effective than placebo injection with saline? In terms of pain on visual analog scale, range of motion measures, average opioid consumption as well as adverse events such as the joint stiffness and muscle contracture. And to meet our goal, only RCTs were included in this study. So this study was done based on a pre-specified protocol registered in Prospero, as you can see in the screen, the ID. After a comprehensive search through Ovid Engine in 3 databases, as you can see in the flow diagram, we started with 380 studies, and at the end, after the deduplication and the screening steps were done, only 4 eligible RCTs were included in our study. With a total number of patients equal to 257, and the total number of limbs equal to 337. Out of them, there was 173 limbs randomized into the intraoperative botulinum toxin type A injection, and the rest into the received intraoperative placebo injection. For the age of the participant in this study, it ranged from 11.8 years old up to 26 years old. So tibia was the most reported site of surgery in the study, followed by femur, then foot.
So for the, after the data extraction was done, we conducted and performed the meta-analysis by using the Review Manager software, as you can see in the screen. And we used the random effect model to combine the result. We also used the risk ratio to represent the dichotomous outcomes, whereas the continuous outcomes were represented by the standardized mean difference. For the heterogeneity, it was assessed by using the R-squared test as well as the p-value, and we assessed the quality for individual studies by using the reverse Cook-Keller bias tool. And for the certainty of evidence for each outcomes, we used the grade criteria. Funnel plot was visually inspected to detect the publication bias, and all the results that fall within 95% confidence interval and the p-value less than 0.04 was considered statistically significant. So here, as you can see in this graph, 3 RCTs were classified as low risk of bias, one only with unclear, and this is due to a randomization issue. And visual inspection of the funnel plot, it was symmetrical, hence there was no publication bias detected in our study for all the outcomes. So here is the result, as you can see. In general, there was a statistically significant difference between the two arms in terms of pain, whereas in terms of adverse event, it was statistically insignificant. Now let's talk about these outcomes individually. As you can see, here is the forest plot of the pain on visual analog scale. So all the studies reported data on this outcome with a p-value equal to 0.02, which is statistically significant. And this is confirmed by the location of this diamond, which is in favor of this arm, which is botulinum toxin type A. Moving to the second outcome, which is adverse events. So also, all the reported, all the included studies reported data in this outcome with a p-value equal to 0.08, which is statistically insignificant, also confirmed by the location of this diamond that crossed the line of no effect. Moving to the average opioid consumption. Two studies only reported data on this outcome. And unfortunately, we couldn't perform the meta-analysis since there is insufficient amount of the available data. But we did the analysis through description or qualitative analysis. As you can see, the result was comparable between the two arms. Same applies to the next outcome, which is range of motion. As you can see, it was reported by 3 RCTs, and it was comparable between the two groups. Moving to the grade criteria. As you can see, all the outcome in the study was reported as moderate. And this is due to the small sample size that affected the impression domain. Moving to the discussion, so in contrast to all RCTs, PERC reported that pain was not elevated after the injection of botulinum toxin type A. And we believe this could be due to the differences in the doses as well as the surgical site of injection of botulinum toxin type A. Our recommendation for the routine use of botulinum toxin type A injection is modest. Hence, we recommend to perform a further RCTs with a higher quality and a longer duration of follow-up and a larger sample size, taking into consideration the differences that I just mentioned before. So we believe, and up to our knowledge, this is the first systematic review and meta-analysis in this topic. We acknowledge that our study has some limitations, including the short sample size, limited number of RCTs, and the short duration for follow-up. In conclusion, botulinum toxin injection showed a significant improvement in the post-operative pain for lower limb lengthening and deformity correction, whereas other outcomes were statistically insignificant. It is worth mentioning our study has been published recently in the Journal of Orthopedic Science journal. And for more references and the published article, please scan the QR code. Thank you for listening. Here's my contact. Any questions? Thank you. And thank you for giving me the opportunity to come from Jeddah and present. Thank you all. Any questions?
Most welcome, Dr. Jawahar.
Okay, thank you.
Thank you for your well-organized presentation and furious one. You were so fast, mashallah. So any questions? Questions or comments for Dr. Jawahar?
Thank you very much, Jawahar. Excellent presentation.
Thank you.
Sorry, Abdullah. So my question, how does the heterogeneity in clinical trials that you are studying affecting the end result or the conclusion of the meta-analysis?
Oh,
and what was the heterogeneity in the...
So do you mean in general or in our study?
In your study and in general.
Okay, so in general, there's two types of heterogeneity. It could be statistical and it could be clinical. So I believe if we had a heterogeneity, it would be statistical. I can go to the, okay, where's the presentation? Okay, so if we imagine the first plot, we have these studies, the confidence interval, the boxes of the estimate. So all of these lines were aligned into one direction, either the arm of botulinum or the arm of the other, of the placebo injection with the normal saline. Hence, this gives us the hint of, this is more statistical heterogeneity, not clinical. So we do not actually care that much about the statistical, since it could be due to many factors, such as the different estimates and different weights of the studies, and how each study affects this outcome. The sample size of each study. Is it large in comparison to the other? And that's all.
Thank you very much. This is a very excellent interpretation. The caveat in collecting randomized clinical trials and analyzing them is weak effect size plus weak effect size will give you a very significant effect size statistically, but that does not mean it's clinically relevant. So it's always clinical plus statistical relevance. Thank you very much.
Thank you so much for your question. Any questions? Yeah. Yes.
Okay. We noticed you have limited number of studies.
Actually, I can't hear you.
You have a limited number of studies.
Yes.
Okay. What would be the reason? Can you, from your point of view, what would be the reason?
Okay. Yes.
What could be the reason?
The reason,
or the different reasons for having a limited number of studies in systematic disease?
Okay, so I believe we have to give more recommendations for the study. Maybe the clinicians do not give that much attention to research or to this topic. This actually, it's a recent topic and recent application of, since it's offline application of botulinum toxin type A. So it could be just recent, as I said before, it's recently started to be applied in orthopedic pediatric, as I said, in the deformity correction, the lower limb. Usually it's used in other specialties. For the orthopedics, this is the first time to use them. So I believe it's a new concept. Maybe after this, they will conduct more. Yeah. Thank you. Any questions?
Well, actually, I didn't have a question, but I would thank you very much for present an important topic, actually. It was really great, sufficient, and useful, actually. And I would thank you very much for a great presentation. Thank you so much.
It's my honor. Thank you so much. My pleasure. Thank you. Thank you. Okay.
We wish you all the best.
Where is the mic? Okay, here. Okay. That's okay. Thank you all.
باسم نادي الطب والإبداع نشكر الدكتورة أشواق عسيري على إدارتها للجلسة، ويتفضل رئيس الملتقى لتكريمها. نشكر لكم مجددا طيب الحضور. الآن معنا إن شاء الله بريك لمدة ساعة. ساعة واحدة حيكون إن شاء الله بداية الحفل.